Hi, it's Doug Holland, LMT, with another massage tip for massage professionals. Today we want to discuss ankle sprains and how I approach them, my tip on how I approach them. Now, we're going to have quite a few athletes coming in with this. This is a common problem. Matter of fact, this week I had a young female athlete who plays basketball. She suffered a sprain to her ankle, and her doctor ordered an MRI. They checked everything out. They've seen that there was nothing overly serious about it, but his recommendation is massage therapy, cryotherapy, which is, we know, is ice therapy on that, and then self-massage and things like this. So they come to our office. How do we help them? What's the best way to help them? I know some massage therapists are nervous about working on individuals that have sprains or any kind of damaged tissue or even bruises and things like that. So I'd like to give you my tips on how I handle this. Now, before we start going to the charts and me showing you ligaments and then going down to the patient to do it, what is my primary goal? Well, my primary goal is this: improve range of motion. So we want to get articulation back into that joint, because we know if the edema is in there, it's deeply inset into that tissue, that ankle doesn't want to move. So that's number one. Two, I want to increase stability. So that individual doesn't feel like putting any weight on that foot because they're afraid it's going to twist again or it's going to move again. And that makes sense, right? That's their nervous system communicating, don't put pressure on it, don't move, don't exercise, don't do any of those things. So what we want to do is we want to reestablish that proper sensation and nerve innervation, which is done through that cellular respiration and that movement of the interstitial fluid. We know that there's very little blood flow down there, very little blood flow. The only way that those ligaments receive nutrition is through that interstitial fluid and cellular respiration. That's it, right? I mean, very little blood gets there. So how do we get in there? How do we dig in between the bones? What's the proper way to dig in between those bones and work on those ligament structures? I'm going to show you that, and I hope you enjoy these tips. But first, let's go down and let's look at the chart so we know what we're talking about, and then we'll go to the patient. All right, well, I hope these charts show up well on the camera here. I think it's important for us to understand the articulations of the ankle if we're going to be able to help our patients. So we know there are three different articulations of the ankle. The first is going to be a hinge joint in the sagittal plane. So if we look here, we see the inferior border of the tibia and the superior border of the talus bone. That's where the hinge joint takes place. Here, right in this groove. So the foot can move in that sagittal plane, which is basically dorsiflexion of the toes, which is flexion, or plantar flexion, was pointing the toes down. Now we'll see injuries of athletes that are involved in like martial arts because they'll kick the side of the other athlete with their dorsal aspect of their foot itself. We generally don't see a whole lot of injury with dorsiflexion. It's usually a plantar hyperextension in the plantar flexion plane. So we're going to be looking in here, and I'll talk about ligaments here in a minute. So that would be the first form of articulation. The second would be more in a transverse plane, side to side. And that's going to be the distal parts of the tibia and the fibula. So we're going to be looking here for the fibula and the tibia. Say the lateral medial malleolus, okay? So these 2 points where they come in contact with the talus bone right here, we're going to see that just a little bit of ability to go side to side or across that transverse plane. And then we have the subtalar joint, okay? That's articulation between the talus bone and the calcaneus bone right in here. Now this is to me one of the most important ones. This is where you're going to see the vast majority of injuries on your patient because of super inversion of the foot. That's going to be the supination of the foot. You can also have eversion injuries in here. Which is, the outside of the foot, the lateral part of the foot turns upward. Very rare. It's usually going to be a lateral injury of the foot rolling outward. Okay, so those are going to be the three. And so if we go back to, let's say, the high ankle injuries here on the inferior tibiofibular injuries, we're going to see that transverse plane injuries usually on people that do skateboarding. That they're going to have it because they're going to have a quick either internal or external rotation. It's going to happen really, really fast. Their foot's going to whip left or right. Then we'll see injuries to that. But if we're looking at the subtalar joint, if we're looking between the calcaneal and the talus bone right there, that's going to be usually our basketball players. It can happen to soccer players, even football players, especially if they're wearing cleats and they have to turn real quick. That's where we're going to see that ankle rolling. Actually, we'll even have patients coming in that aren't athletes that step off of a curve. You've heard of that a million times, people stepping off a curve and then their ankle rolling. So that's where these injuries are going to take place. Now, let's go to the ligament chart here. Hopefully it shows. I see a glare in here. Hopefully it's coming through. All right, so if we're looking, let's just focus on the ligaments in this particular area here, because this is where your primary injuries are going to take place. So, I have found, just matter of fact, on this patient, the interosseous talocalcanean tendon right here, right in this little groove, I found injury. That's where that ligament was damaged. So, that one right there, that's a tough one, because I'll show you how I dig in there and get to that, but that's a tough one. But most of the time, you're going to find the injury is going to be on this calcaneofibular ligament right here, which attaches to the fibula and the calcaneus bone. This is a good one. This one gets and then we also have the anterior tibiofibular ligament. So generally speaking, most of our injuries are going to take place here. If you get an odd one out here, which is a possibility, I don't even it's too much to discuss how many different ways you can do this. And then the cuboid notch, sometimes they'll injure if there's a strike in the cuboid notch itself. But I'm going to take us down to the table. I'm going to show you how I work these particular ligaments in this area, and even on the dorsal aspect here between the tibia and the talus bone in here, just so that we have an idea how to strike these particular ligaments, and I hope it helps. All right, down to the table. So we're going to do a quick visual inspection of the foot. We're going to look, most of the time there is going to be edema. That's fine. I work on patients with edema. Even if it's minor bruising, I'll still work on that. If it's deep bruising and it's been within the first 72 hours, we're not going to do any work on them. We're going to tell them to wait. I like to start working on the ankle about 5 days, 6 days in, because if it's a fresh injury, we just don't want to work on the real big black deep bruising that we see. So once we do the visual inspection, we see that there's no cuts that we're going to get our fingers into. Then what I like to do is start to test which particular ligament might be the problem. So we're going to be looking at the deep ligaments, which are really deep. We're going to be looking at the peripheral ligaments, which are going to be more superficial, and of course the retinaculum that actually holds down the flexors here on this side. And the way I do that is I lift the foot up, I put my hand underneath the posterior aspect of the calcaneus, and then I supinate the foot, which is inversion, or I pronate the foot, which is eversion. Eversion, inversion, just like this. And I just gently rock it back and forth. So that's the frontal plane. We're working the frontal plane on this one, right? By doing the inversion and the eversion. Then we want to work in the sagittal plane. We're going to see if it's at the upper part of that hinge joint. So we're going to go ahead and plantar flex the foot and then dorsiflex the foot. Plantar flex, dorsiflex. Plantar flex, dorsiflex. And I do it, I'll speed it up a little bit to see if they go ow, 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 or there's anything that's going on in there. And then of course the way to work the transverse plane is I hold a little bit better on that calcaneus, and then I circumduct the ankle like this across that transverse plane. Now, how I discover what ligament it's generally going to be on this ankle rolling is I take my thumb and I just start palpating in between. You can see that protrusion right there of the talus bone, and then you just come right in that groove and you just gently walk and palpate, and boom, that's generally where you're going to find it if it's a good ankle roll. And you'll feel that ligament that's holding that together. You can come up underneath here between the calcaneus and the talus. Boom, there's another one right there. I can feel that ligament, and I'll palpate, and then all of a sudden you'll feel the patient flinch, and then you know you got it. Now, how do we work these particular, like between the talus and the calcaneus or in these grooves? Well, if we're working on this particular aspect, and now this can be uncomfortable for a lot of people, just plantar flexing people's feet. A lot of people don't like that. That's an annoying feeling anyways, even if you're healthy. But if you take your fingers, you just gently plantar flex, you can take your fingers and you can walk those ligaments right in between. Boom, I'm in the middle now, and I'm going through like that. I'm going to do it with the other hand so that maybe you can see it better. So I'm working inferiorly to superiorly as I'm striking these ligaments in here, because that's the direction of this particular aponeurosis. Right through here is you're going right from inferior to superior. And so I will drive edema. I'll drive edema out, and I'll add 2 fingers on either side, and I'll go through, and I'll just work my way up. See, I'm just doing that little walking motion, that pinching motion. As I go up, I'm pushing that fold of the hypodermis, that deepest layer of the skin. I'm moving that along so I can get down into where the ligaments and fascia are. Okay. So that's how I'd work the dorsal aspect on the hinge joint here. How am I going to work the inversion, eversion, the frontal plane? This to me is one of my favorite tricks. I like to do extension, move the foot inferiorly from the knee. I like to do extension by pulling. I put my holding hand on the top of the dorsal aspect of the foot, and I get a really good hold on the base of that calcaneus. And this is the trick here, because you got to find that comfortable spot right here in your hand that you can hold this but also articulate your thumb. Okay, so I'm going to hold this over here, and I'm going to use equal pressure on the heel, and I'm going to pull towards me. I'm using the table to my advantage. This is where having your chair sitting just right, because my forearms on either side are pulling, so I don't have to use my biceps so much. I'm just barely pulling with I'm actually using my lats. I'm using my lats to actually pull this foot. And this is going to help you not to have fatigue as a professional. Is if my arms are off the table and I'm pulling, I'm not going to get much work done because I'm going to fatigue. But if I can keep my arms at the base of the table, this is good positioning of the foot, pull an extension, and now that I've opened up the distance between the talus bone and the calcaneus bone, now I can work right in that groove. Now see, the patient's flinching already. You can feel the flinch. See how they're pulling? Because this can be very uncomfortable right there. And I can work that tendon all the way up, nice and gentle. Now, you can hold it with this foot or this hand, and then work with the tip of your finger, and you can go into those little grooves and work all the way through there too. But so what I'm going to do is a lot of acupressure, a lot of thumb work, and I'm going to work and root and work, and then I'm going to, and this is what might bother him a little bit, I'm going to invert the foot. That's where the injury, right? I'm going with the injury, and I'm going to invert that foot, and then I'm going to work that. Whoa, you could feel the patient flinch on that one. Yeah, that one's not going to feel too good when you do it. But if you stretch those ligaments and you give that signaling, that nerve innervation, you give that signaling that it's okay, that the person's going to be fine, they're going to be all right. Half of injury in sport is confidence. Half of all healing is confidence. Don't you agree? You know, just knowing what the problem is, knowing that it can get better, makes people get better. If they think they're going to re-injure or they're not confident, that's going to have a big problem. So the more we work this soft tissue, we work those ligaments, and we get this foot feeling better, and they walk out of here, which most of them do, they literally walk out of here, their confidence goes to the roof, they start to heal immediately. So use the acupressure. Now, I also like to take the thenar eminence of both of my thumbs right in here, and I lift the foot up, and I place both of those pads right underneath the lateral medial malleolus, okay? And by doing that and letting that foot rest, I can rock it back and forth like this. So what I'm doing is I'm moving my hands inferior to superior, opposite of each other, and I'm forcing that transverse plane to take place. You see how it's going back and forth? And you can make it go faster and faster. Now, if it's breast injury, they're not going to let you do that, but as they keep coming in here and we keep progressing, I'm going to be rocking that foot back and forth. That's going to bring a lot of relief and fresh circulation and interstitial fluid into this area and help that to heal. Now, another thing I like to do is actually circumduct the entire ankle. So I'm holding the calcaneus in my hand, and I'm just gently, you don't squeeze hard on these toes, they don't like that, gently rotate that ankle. As one of my very early practitioners taught me, one of my earliest teachers said, "This is delicious." She always used to say, "Man, this is delicious." And it is. Most people love to have their ankle rolled like this. It feels good. Okay, so we can do the transverse plane. This also works the transverse plane. I don't really do too much stretching in the sagittal plane. I haven't really found it to be of much benefit at all. But if we're just strictly working the ankle, this should bring a lot of relief. Well, I hope you enjoyed that tip on how to help your patients with ankle sprains. I know you'll have much more confidence the more you practice it. And just remember this, friends. If there's no discomfort on the table, well, we didn't really help them much more than take a nap.